All right, so we'll get started now. Everybody done with the questions? Any questions about the questions? Okay. Can everybody hear me? Okay. Great. There's one question in the chat. Okay, we're good. All right. So today we're going to be going over the year 2 topics, kind of a bunch of different stuff, but these are the topics that we're going over this year. Obviously the colon is kind of a big topic. So at the very end, I'll list the kind of the topics for year 1 that you should review on your own, but this is what we're going to be talking about today. So first we'll kind of briefly cover the anatomy and physiology of the colon, okay? So first you have your colon anatomy. It's about 150 centimeters in length. It's 4 layers to remember. So you have the mucosa first, a simple columnar mucosa with goblet cells, doesn't have any villi like the small bowel. Next you have the submucosa. This is your strength layer. So this is always very important for us when doing anastomoses. Then you have your muscularis propria, which contains 2 kind of separate muscular layers. You have the inner circular layer and then the outer longitudinal layer. And then you have the serosa covering the outside. As you'll probably know, the cecum is the lightest
portion. So the muscularis is really the
so
strength layer. Submucosa is important because that's where the lymphovascular structures run through. So that's where once, let's say, a cancer penetrates into that layer, that's when we get concerned that there's lymphovascular spread of a cancer.
So we have the cecum is about 7.5 to 8.5 centimeters. This has the thinnest muscular wall. And kind of just generally thinking of the right colon, as it goes up, it overlies the inferior pole of the right kidney and the second portion of the duodenum. So it's just important when you're mobilizing the right colon to remember kind of what structures are right there when you're doing your mobilization. Take care not to injure them. And then you have your kind of another important thing to remember is your rectosigmoid junction is at the sacral promontory. And this is usually where the tinea coalesce and they kind of form one longitudinal muscular layer. And that's kind of how you can identify from where the sigmoid ends and the rectum begins. So a little bit more anatomy. Just remember that the transverse and the sigmoid colon are completely intraperitoneal. There's the sigmoid colon has a longer mesentery, which allows more mobility and can make it prone to twisting like a volvulus. The ascending and the descending colon are fixed to the retroperitoneum. And then let's review the vascular supply of the colon. So we're going to kind of go through. So we're going to go through in the numbered order. So team 3, what is vessel number 1? Yeah.
The colon. So the vascular supply starting with 3 is the ileocolic. Then you have the right.
Yeah, number 1 is the SMA. What numbers did they want?
You can go through all of them if you want to.
Okay. Number 1 is the SMA. Number 2 is the right colic. Number 3 is the ileocolic. Number 4 is the middle colic. Number 5, the left colic. Number 6 is the sigmoid.
So close. 5 was the IMA here, and then the left colic, and then you have the sigmoid. And then you have kind of your marginal artery is what ends up connecting the vascular supply of the SMA and the IMA. Nice job, guys. So then you have your venous drainage. So typically the venous drainage of the colon kind of follows the arterial supply. But to remember the major vessels, you have the SMV, which follows along the anterior and to the right of the SMA. It crosses posterior to the neck of the pancreas to join the splenic vein to form the portal vein. And then your IMV, it courses posterior to the body of the pancreas and joins the splenic vein before the splenic vein joins the SMV to become the portal vein. So that's kind of how your vascular supply goes. There's another good picture over here. You can see how they kind of follow directly with the arterial supply, except the IMV kind of goes around to the side and then it joins up with the splenic vein over there. Just kind of briefly about colonic physiology. It's in charge of a lot of the absorption of fluids. As we learned last week, the small bowel does most of the absorption, but the colon does a lot of absorption. It's very important through absorbing water through passive reabsorption, about 5 to 6 liters a day. Sodium reabsorption is active, stimulated by aldosterone and glucocorticoids. And then you have chloride, which is passively absorbed. You also have secretion of potassium and bicarb with these active electron pumps and channels. So if you can think about how if you are having like persistent diarrhea, this could lead to some electrolyte abnormalities that you would have to account for if someone is having some diarrhea. And then something to remember that the colonocytes absorb the short chain fatty acids from that the bacteria break down, and this serves as the energy substrate for the cells. And the appetite likes to test on butyrate specifically, is one of the short chain fatty acids. So that's one to try and remember. So we're gonna have a little review. So let's go with team 4. What are the 4 layers of the colon wall? Team 4, where are you guys? You're my team. All right, they said mucosa, submucosa. There's 2 more. Muscularis and serosa. Okay, good job, guys. There you go. And typical mic problems. All right, so team 5, what is the arterial supply to the ascending colon and the first 2/3 of the transverse colon? Like what's the major vessel and what are the branches? Nobody's mic is working today. Cool, 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 cool. What are the branches of the SMA that supply the colon? Great. Ileocolic, the right colic, and the middle colic. All right, so what is the arterial supply to the distal third of the transverse colon, the descending colon, the sigmoid, and the upper rectum? Kind of the major vessel and then the branches. Let's go with Sir Jonk.
So the arterial supply is the IMA.
Mm-hmm. What are the branches of the IMA?
The left colic, the sigmoid, and then the superior rectal.
Great, good job, guys. And then Sir Jonk again, what connects the arterial supply of the SMA and the IMA?
The marginal artery.
Nice.
Nice, again.
All right. And then the surgery library. What's the main nutrient for the colonocytes?
Short chain fatty acids, specifically butyrate.
Great. Good job. Okay. So now we'll kind of go on to some of our topics. First, we're going to start talking about large bowel obstruction. These are most commonly due to cancer. They can also be caused by diverticulitis and also can be caused by bowel volus is the next most common thing. These usually present with pain, with cramping. They're usually very distended. You can see kind of a progressive narrowing of their stools, or it can have can be completely obstipated without any bowel function. They can be complicated by signs of systemic intoxicity and perforation. Does anybody know what is the most common site of perforation? So surgery library again.
The cecum.
Nice. And then can you guys also tell me what's the role of a competent ileocecal valve? How does that affect a large bowel obstruction?
So it's actually bad to have a competent ileocecal valve because then or it's more risky, I should say, because then you run a greater risk of perforation because you can't get offloading of pressure backwards into the small bowel.
Correct. So there's this thing called the law of Laplace that has to do with wall tension, and it relates to the pressure and then the radius of the structure. And then because of that, you end up with more pressure on the greater tension on the wall. And as we said before, the cecum has like the thinnest wall, the least amount of muscle, so it's most likely to perforate. And then the type of diagnostic imaging that you would get, you could get an
Again, sorry, just interrupt. Just a comment on Laplace law. It really kind of, if you saw, can you go back to that? Yeah. So see how you have the transmural pressure times the radius over wall thickness. Also of note, if as a radius goes up, the tension goes up. So really, the cecum has the largest radius, right? And that's kind of where the tension really comes from, is like just the fact that it's wider than the rest of the colon. Not necessarily the wall thickness, it's the radius.
Yeah. So for imaging for large bowel obstruction, you can get an obstructive series. You can just get a KUB as well, just to get, most importantly, you want to look at the dilation of the cecum and see how big it is. I think the kind of textbook old imaging that people used to get was a contrast enema to look at this, but this isn't really commonly done anymore since CTs have become so common. We usually get a CT with oral and IV contrast. That way you're able to see how far the contrast is able to go and if the contrast is able to pass through whatever is causing your obstruction, see if it's completely obstructing or not. And then eventually you do need a colonoscopy, usually for decompression, either for stenting, maybe a biopsy to see what is actually causing the obstruction. So some kind of things to think about with an obstruction: if you have increased pressure, it leads to venous congestion, which ends up leading to arterial congestion, which leads to thrombosis and necrosis. So it's kind of this increased pressure cutting off the venous supply, which then interferes with arterial supply, and that's why you can develop ischemia. With this problem, you can end up with bacterial overgrowth, and obviously can get problems from that. The treatment of a large bowel obstruction really depends on what the actual cause of the obstruction is, since different causes have different managements. But kind of classic treatment for everything, you want to make sure the patient is resuscitated, make sure that they're in PO, that they have decompression, either proximal decompression. They should get serial imaging to make sure that their obstruction isn't getting worse. If the obstruction is due to malignancy, then you kind of have a few different options. based on where the obstruction is, and then what exactly is causing the obstruction. You can sometimes do stenting if the mass is either unresectable or if it can be stented to kind of give you time for more preoperative like workup and management of a malignancy before actually taking for a resection. If they present with a mass that's been able to be worked up and it is resectable, then as long as the patient is clinically stable, you can actually do a resection. And then if the patient is clinically unstable and they may have already perforated or something like that, then you usually do a proximal diversion. You don't try and stent and stuff if they're already perforated. Obviously, they have some more issues then. So then you usually do a proximal diversion. You don't go and try and take out the mass. You want to do what's fastest and quickest to decompress the patient.
And this would be in the form of a loop stoma, because you don't want to then leave a segment. So you don't want to do an end and then leave like a stapled off segment that then is still obstructed, essentially a closed loop. So it'll be a loop, usually a colostomy.
So then a pseudo obstruction, also known as an Ogilvy's. So this is usually managed with decompression, electrolyte repletion. Usually get x-rays to continue monitoring the dilation of the cecum, see how big it is. You can try neostigmine. This should always be done in the ICU. And you can try neostigmine a few different times. If that doesn't work, occasionally GI can go in and do a colonoscopy and put like a more proximal tube. They can basically put a really long rectal tube in. And then, it's really a lot of like electrolyte repletion and hemodynamic status, making sure that they improve that way.
Just to know about pseudo obstruction, before you do any kind of neostigmine, you have to rule out any other actual cause of obstruction beforehand. Pseudo obstruction is kind of like a diagnosis of exclusion. And so if you can imagine, if you then give neostigmine and there is actually an obstruction, you can just cause them to perforate. So that's something that's important to do before you give neostigmine. And neostigmine is very effective. It's like 97, 98% effective usually for these conditions.
So now we're going to kind of talk about volvulus. This is another cause of a large bowel obstruction, but obviously it's kind of its own specific etiology with management. So sigmoid volvulus specifically is more common in the elderly. A lot of them typically have some sort of coexisting psychiatric illness. Usually it's diagnostic on a plain film most of the time. You can see an example over here on the right kind of this shape that you get, kind of this like loop shaped. It's described as like a coffee bean, or they say if you have contrast, there's like a bird's beak narrowing. But I always think of a coffee bean or just like a bean with the line in the middle. So there's a little cartoon over here on the left, and then an X-ray here on the right. You can kind of see it. A sigmoid volvulus specifically is usually initially managed with an endoscopic decompression. It works in 65 to 90% of patients. They usually also place a long rectal tube to continue the decompression to try and prevent recurrence. But the recurrence rate, that being said, is very high still. So a lot of times these patients usually end up needing a surgery unless, they're like a very poor surgical candidate. It's not within their goals of care, that sort of situation. This is more common in the elderly. So it's a lot of times a bigger discussion. And if you do end up taking them for a resection, then you would consider a primary anastomosis versus an ostomy. It would depend on kind of their clinical stability. Are they clinically stable? Are you doing this after it's been decompressed and it's well perfused? Or are you doing this because it's volvulized and become ischemic? And then in that case, you probably wouldn't want to do an ostomy, or wouldn't want to do an anastomosis, and would rather do an ostomy. And then the other kind of major volvulus that we talk about is the cecal volvulus. This is actually more commonly seen in younger patients. A lot of times younger women is like the classic in test questions. It's due to a failure of fusion of the posterior ascending colon mesentery to the retroperitoneum. So it allows the cecum to just be more mobile. You can also see this one on X-ray. Again, it kind of looks like a coffee bean, but if you think of the line in the middle, this time it's pointing down to the right lower quadrant, as opposed to a sigmoid volvulus, it kind of points down to the left lower quadrant. The advantages of cecal volvulus is usually you can't actually, endoscopic decompression, there's a really high failure rate with that. And also, you're going into the cecum, there's risk of perforation. So endoscopic decompression is not the best management for these. So it's usually a right hemicolectomy. You'll kind of read about, and there is the option of doing what's called a cecopexy and a cecostomy tube, which basically just means you detorse the colon. You kind of pexy it to the abdominal wall and then place, I was reading usually it's like a Malacot drain, like through the skin into the cecum, and then it's kind of sutured to the abdominal wall to keep it in place, to keep it from being a free perforation. If the patient isn't a candidate for right hemicolectomy, but this tends to be very ineffective, and it's associated with a lot of complications. The cecum comes off of the abdominal wall, the drain is free, you end up essentially having a free perforation in the abdomen. Not commonly done. So usually what is done is a hemicolectomy. So let's do a little bit more review. So let's go with, let me see who all the people we have here are. Let's go to the consult room. How does obstruction lead to bowel ischemia?
You get venous congestion and then it cuts off the arterial supply.
Yeah, and end up with necrosis. Nice. Let's see, vascular team. What is this?
Looks like a sigmoid volvulus.
Yeah. And then what about this one?
A cecal volvulus.
Nice. So you can see how they're kind of pointing in different directions. So this one's kind of pointing towards the right lower quadrant, how I think about it. And then this one was pointing towards the left lower quadrant. So it's kind of how you can tell. It doesn't always look this nice. Sometimes it's like a line in the middle and you're not quite sure where it is. But that's kind of those are classic pictures that you can think of. Okay, so now we're going to move on to polyps and malignancy. So polyps are abnormal growths from the lining of the colon. They can be neoplastic or non-neoplastic. Neoplastic polyps are typically adenomatous, and our non-neoplastic polyps are typically hyperplastic or hamartomas. Polyps can be pedunculated, which means they have a very kind of narrow, long base, or they can be sessile, which means that they're very flat and wide. Glands in the adenomatous polyp, they can be organized in a tubular or villus or tubular-villus fashion. So when you're looking through like a GI's colonoscopy note in their biopsies or polypectomies that they did, you'll see kind of these words to describe it. And then the pathology will go further into saying if it's tubular villus or tubulovillus, but these are kind of the descriptions of the colonic polyps. Tubular polyps less than 1 centimeter have like a 1 to 2% chance of having constant cancer, and villus polyps that are greater than 2 centimeters have up to a 40% chance of having cancer in them. So the polyposis and non-polyposis syndromes, these are kind of syndromes that we tend to be tested on pretty frequently, so they're good to review. The polyposis syndromes, you have your familial adenomatous polyposis. These patients have 100% risk of developing colon cancer. This is the one where you see the colon and it's just full of hundreds and hundreds of polyps. FAP can also be associated with Gardner syndrome. This is where they also get desmoids, osteomas. You can have those estranumary teeth. Or it can be associated with Turcot syndrome, where they get the malignant CNS tumors. FAP is associated with the APC gene. That's commonly tested as which gene mutation is associated with FAP. And this is also associated with periampullary carcinomas. So in addition to colonoscopies until their eventual colectomy, they actually, even after the colectomy, have to get screening EGDs to look for this periampullary carcinoma. It's pretty common in this population. Another polyposis syndrome is the mutated YH associated polyposis. About 75% of these patients will develop cancer, colon cancer. It's also known as like an attenuated FAP, and this is associated with the MYH gene. And then you have your hematomatous syndromes. These have a lower likelihood of developing colon cancer, but it still exists. So you have your Peutz-Jeghers syndrome, juvenile polyposis, the P10 syndromes, and these are, you get hematomatous polyps with all of these. And then here's just kind of another table talking about the different gene mutations and different things that you can see with each of them. So kind of something to remember is that the majority of these are autosomal dominant. Just the mutated YH is the autosomal recessive, but for the most part, they're autosomal dominant. Here are the genes that are kind of associated with each. Wasn't on the last slide. So Peutz-Jeghers is the STK11, juvenile polyposis is these, and then the P10 is a P10. And then you can see here some of the different things that are associated with each of these different polyposis syndromes. So they all kind of have a bunch of unique things that are associated with them. And then non-polyposis syndromes typically is the Lynch syndromes. So the genetic mutations for these typically are the DNA mismatch repair genes. So this is, you have the PMS2, MSH6, the MSH2, and the MLH1. The MSH2 and the MLH1 are the ones that are more commonly tested on. So these are the more common mutations. There's kind of two different forms of Lynch syndromes. You have Lynch 1, which is just colon cancer, and Lynch 2, which is associated with endometrial carcinoma, ovarian cancer, pancreas, stomach, small bowel, biliary, and urinary tract carcinomas. The classification of Lynch syndrome, you can look at the Amsterdam 1 criteria. So this is kind of the 3-2-1 rule is a way to remember it. So it's 3 relatives with adenocarcinoma of the large bowel. One of them has to be a first-degree relative, 2 successive generations, and 1 person is diagnosed before the age of 50. So that's the Amsterdam 1 criteria. The Amsterdam 2 criteria is kind of a modification of the 1 criteria. So you have 3 relatives with HNPCC malignancy. 1 is a first degree, 2 successive generations, and at least 1 diagnosis before age 50. Have to have ruled out FAP, and it has to be like path confirmed. And Lynch syndrome is always tested on also. It's one to remember. So colonic polyps and the pathogenesis of colon cancer. So you have kind of these 3 different routes and stuff of the way that these genetic mutations end up happening and end up leading to malignancy. So you have the chromosomal instability, the microsatellite instability, and then the CpG island methylator phenotype. So we're going to kind of go through each of these a little bit individually, just kind of briefly overview and remember them. The non-hypermutated mutations, about 84%, this leads to chromosomal instability, which ends up with missegregation of the chromatids. So you have gains and losses of chromosomes and segments. If you remember back from medical school, your lectures on mitoses. Eventually, you end up with loss of tumor suppressor genes, like the P53, DCC, SMAD4, and you can get a gain of the proto-oncogenes, BB2. So this diagram down here at the bottom, I think, is pretty good to help kind of remember the progress of things. I do better with pictures, so this helps me kind of think. So you have your normal epithelium, you get an APC mutation, so then you end up with a small adenoma that's been added on with a KRAS mutation, and then you end up with a larger adenoma, and then the P53 mutation is the loss of suppressor genes, and then you end up with adenocarcinoma that's able to spread. It's kind of a nice very, very simplified way of thinking of it. But it's a nice little picture to kind of remember the progress. The hypermutated, the kind of non-silent mutations, about 16%. These result of errors in mismatch repair, resulting in mutations in repetitive sequences and cause microsatellite instability. So this is your like BRAF and TGFB2 mutations. You're silencing MMR genes. So this is the MLH1, MLH3, MSH2, MSH3, and MSH6. So these are the ones, if you remember, associated with Lynch syndrome. These, a lot of times with Lynch syndrome, these are associated with like right-sided or more proximal colon tumors. They actually are associated with a better prognosis. And then we have our CpG island methylator phenotype. So this is when you get hypermethylation of the promoter genes, you get loss of transcription. This is the serrated polyp pathway. Also your BRAF mutations. It can also lead to the loss of the MMR and therefore microsatellite instability. So this is kind of another little diagram that shows how things go. So you have your normal colon, your hyperplastic polyps, you have your BRAF mutation, and then more things end up happening with intermediate lesions, then you end up with your cancer. So just kind of a general progression of how you end up with malignancy. So since that was just like a bunch of facts, we're just going to briefly go over just a few of the important genetic mutations. So let's start with, let's go with team 3 again. Actually, Elmhurst, is anybody there? Yeah, Elmhurst. What's the genetic mutation for FAP? Is Joe's mic not working? I know there are technical difficulties sometimes. All right, let's go to the Bronx, VA.
Can you hear us?
Yeah.
APC.
Great. How about Lynch syndrome?
MSH. MSH. And MLH.
Right. MSH2 and MLH1. Those are the most common ones. There's more, but those are the more common ones. Oh. And then do you guys remember the kind of order of mutations with this picture? There was one that happened first, one that happened second, and then one that happened third.
APC, KRAS, and then P53.
Nice. Good job, guys. We'll keep
Thanks.
moving on. So there's just a kind of another general overview of how you get to different adenocarcinomas. So you have your classical pathway and then your serrated pathway. So your serrated pathway, just remember the mutations are the BRAF, the KRAS mutation, microsatellite instability. So you end up with initially some small, these are non-dysplastic, and then you end up with some larger ones that are in the more proximal and more distal colon, and then eventually you can get serrated adenocarcinoma, as opposed to your classical pathway, which is like the APC mutations, also with KRAS and then the P53, where you get a conventional adenoma and then you get adenocarcinoma. So it's kind of a repeat of the same thing. So colon cancer, the US incidence is about 130,000 people a year. The annual deaths is about 50,000 people. These have declined recently in the US because of pretty effective screening programs and improvements in treatment. There is a little bit of an increased incidence in some other parts of the world, but still with a decreased mortality. There's still some disparities that exist in terms of colon cancer. It's more common in Men, proximal tumors are more common in women. There hasn't been as much of a reduction in the incidence and mortality of colorectal cancer in the African American population. It's gone, there's been more of a decline in other populations. And then the lowest incidence and mortality is actually in Asians and Pacific Islanders. So the different risk factors for colon cancer, you kind of have your modifiable and the non-modifiable risk factors. So modifiable risk factors would be obesity, smoking, alcohol consumption, red processed meats, physical inactivity. Those tend to be associated with colon cancer. And kind of your non-modifiable risk factors. This is your family history of colon cancer, the polyposis syndromes, IBD, diabetes, and then kind of your risk of metachronous colorectal cancer, about 3% at 10 years. So screening for colon cancer, this is a big table, but still doesn't even have everything that you need for screening. This is kind of your initial screening. So I did want to point out, just for your average risk person, the guidelines recently changed. So the initial age for screening should actually be at 45 years old, not 50 anymore. So the recommended screening test, you can kind of see here, remember there's a lot of different things that people are able to do. Obviously, I think colonoscopy is the most sensitive, so that's what's recommended, but there are other options, and that's once every 10 years. They can get a flexible sigmoidoscopy, or there's like the CT colonography, and then there's the annual FOBT that they can get. If someone has adenomatous polyps, then they need an annual colonoscopy if they have more than 5 polyps. If they have polyps on their first colonoscopy, then they should get a repeat in 3 years. If no polyps, then they get it every 5, and if they have more polyps, they get it every 3. For colorectal cancer, they need another full pre-treatment colonoscopy after the detection of their cancer, if they haven't had a full one already. And then they need another one again 12 months after their resection and every 3 years. For ulcerative colitis, they usually get a colonoscopy at diagnosis, and then 8 years for pancolitis, and then after 15 years for left-sided colitis. But they usually get, once they start getting the colonoscopies, they get it every 1 to 2 years with biopsies to look for dysplasia. FAP, they start getting colonoscopies at 10 to 12 years old. They get an annual flex sig and to look at the amount of polyps, and then they actually, a few years after their first start seeing polyps, then they start getting an upper endoscopy to screen for the periampullary tumors. The attenuated FAP, they start getting screened at 20 years old. Lynch syndrome's usually 20 to 25 years old. And then for women, they also need to get endometrial aspiration biopsies because they're at high risk of endometrial cancer. And then for familial colorectal cancer, in a first degree relatives, it's either 40 years old or 10 years before the age of the youngest affected relative. And then they get a colonoscopy every 5 years. So it's kind of a lot of information, but it's a lot, and there's a lot of different criteria to think about for different patient populations. So the diagnostic kind of workup for colon cancer, they do need to have a complete colonoscopy because there is a risk of having synchronous lesions in the colon. Just because you have one colon cancer in your sigmoid doesn't mean that you can't have colon cancer anywhere else in your colon. So there is a risk of having colon cancer somewhere else. You need a full, complete colonoscopy. If you have, a fully obstructing mass and you're not able to do a full colonoscopy, then they usually do a CT colonography to look for any other masses or lesions. The further workup of colon cancer, you get the CT chest, abdomen, pelvis. PO and IV contrast. This helps assess the location of the mass, nodal involvement, to assess for distant metastases, and obviously to assist in some surgical planning. And then you also get a preoperative CEA level. So here we're going to talk about the TNN staging of colon cancer. So this is what Dr. Han was referring to earlier in terms of the importance of the layers in terms of colon cancer staging. So IS is in situ, that's if you just have colon cancer within the mucosa. 1 is if it's invading the submucosa. 2 is the muscularis propria. 3 is submucosa and the subserosa, excuse me. And then 4 is if it's invading into adjacent organ or visceral peritoneum. And then end staging for colon cancer, N1 is 1 to 3 lymph nodes, and then N2 is 4 or more nodes. You can kind of see a little representative picture here of the invasion and the different T staging. So as we all likes to look at the different staging of colon cancers based on the TNM staging criteria. So stage 1, that's going to be your T1 and T2 that are also N0 and M0. So that's if your tumor just invades through the muscularis propria, but not any further, then you're still a stage 1 cancer. And stage 2, this is when you still don't have any nodal metastases, but you're a stage T3 or T4, so that can invade through the subserosa or beyond, or invade into some adjacent visceral peritoneum or structures. That would be 2B. And then once you get any sort of nodal involvement, that's when you get into stage 3. So you can have 3A and 3B based on some different criteria. And then A, B, and C. And then stage 4 is when if you have any distant metastases, then you automatically come as stage 4. And some of the most common sites for metastases are, as I'm sure we all know, is the liver, the lung, that's why you get a CT chest. The brain can have some metastases in bone. Up to 30% of patients actually have metastases at diagnoses. And actually having synchronous lesions is a worse prognosis than if you have metachronous lesions. So all the different staging things to think about. This is something, some of the staging for different cancers, we at least talk about it a little bit more in colon cancer, so it's easier to remember for the ABSITE, but it is still something to just kind of go back and review the different staging for these common cancers that are tested. So the different treatments for the different stages. For stage 1, it's surgery only. For stage 2, it's surgery plus or minus adjuvant chemo in some select patients. If you have stage 3, then it's surgery and adjuvant chemo. Stage 4, you end up with chemo, you do immunotherapy plus or minus surgery and radiation based on how they respond. The adjuvant chemotherapy for these cancers is usually a FOLFOX therapy, and occasionally the CAPOX therapy. Of FOLFOX is the more common one that we see, the 5,4-uracil and the leucovorin and oxaliplatin. So operative considerations, if the patient is, if you're able to do a resection for their colon cancer, there's some things that you have to consider, as I'm sure we're very well aware of here, is the ERAS bundle. So also all of our patients get the colon bundle. As you all know, they get the preoperative bowel prep and the antibiotics, which is shown to improve outcomes. People usually get their stoma ostomy site marked, typically if there's a concern that they're going to need an ostomy. The goal of the operation is for our zero resection, so clear margins with the full mesentery and central nodes for the mass. So you get 5 centimeter margin of normal bowel on either side of the tumor. And then you do what's called high ligation of the arterial supply. So you get the full lymphatic drainage of the mass. However, you want to maintain adequate blood flow to the surrounding colon that you have to make sure that there's no concern for ischemia, extra anastomosis. You want to minimize anastomotic tension. So this sometimes requires mobilizing a lot of the colon to make sure you can do your anastomoses. Oh, 1 second. Something happened. I don't know where my PowerPoint went. Here we go, we're back. And then you want to have a complete mesocolic excision, and you want a minimum of 12 lymph nodes for your resection. So kind of briefly to touch on malignant polyps. You can do a polypectomy if the resection of the polyp is sufficient. If you only have invasive carcinoma in the head and neck or the stalk, and you have a clear margin and also have favorable histology, you do need a colectomy if the polyp is invasive at the base, if there's positive margins, if it's like a sessile polyp, then you have to do a colectomy because there's more concern for invasion. So you can kind of see here this like carcinoma in situ or the invasive carcinoma, can kind of see how it's all up here. And if you did a polypectomy, you would get the whole pedunculated adenoma, but here with the serrated, you wouldn't be able to get it all. And then if you're doing operative intervention, the laparoscopic approach is preferable to open because it results in fewer short-term complications and shorter length of stay. If you're doing a right hemicolectomy, then you get the cecum and the proximal right colon and the terminal ileum. You can do more of an extended right hemicolectomy if you have a mass within the hepatic flexure or the proximal transverse colon. You can do a transverse colectomy if you have it in the kind of exact middle of the transverse colon. I don't think this is done very commonly, but it is possible. And then you can have, this is a real extended right hemicolectomy if you have something in the distal transverse colon where you go all the way over to the splenic flexure and get the first part of the descending colon. You have a left hemicolectomy over here. It's just where you're just taking the splenic flexure and part of the descending colon. And then you can also have your sigmoidectomy. So the major things to kind of think about and consider for these is just the blood supply. You just want to make sure that you have adequate perfusion and blood supply of the remainder of the colon. Oh, here we go. So for metastatic disease, the overall 5-year survival is about 6%. If you have a single resectable liver metastasis, the 5-year survival is 71%. But the resectability depends upon location, invasion, remnant liver function. And surgery is the only curative therapy for liver or lung metastases. And you also have to be able to resect the primary tumor if you're also going to undergo a metastasectomy. And then if the metastasis itself is unresectable, then the primary resection is not required of the primary tumor. So basically, unless the primary tumor is causing a complete obstruction, then it doesn't have to be resected if you already have metastases that they are going to be getting therapy for. And then recurrent disease, most recurrences occur within 3 years, nearly all within 5 years. Surgery is usually the primary therapy if it's resectable, but it's still fairly poor prognosis. They would get adjuvant chemotherapy, and occasionally chemoradiation is their only option. And then just to kind of briefly talk, there are other colonic neoplasms that you can get. It's not all colonic adenocarcinoma. So just kind of to talk quickly about these, I'm not going to go into them too much. So medullary carcinoma, you can actually get it in your colon, mucinous adenocarcinoma, signet ring cell carcinoma, you can get neuroendocrine adenocarcinoma, squamous cell carcinoma, small cell carcinoid, lymphoma, and sarcoma. These are all neoplasms you can get in your colon. So, definitely worth paying attention to the pathology to make sure it's not something different or unique when it gets a biopsy. And finally, we're going to talk about colonic motility disorders. So we're going to talk about functional constipation and irritable bowel syndrome. So functional constipation is when you have infrequent bowel movements, straining, or hard stool. Some of the causes are lifestyle, it could be medications, medical conditions, it could be structural, or you can have something called colonic inertia. There's actually something called the Rome criteria for the diagnosis of constipation. They have to have 2 or more of this criteria here, where they have straining for like more than a quarter of their bowel movements, and complete evacuation, hard stools, 3 or fewer bowel movements weekly, if they have to do any manual maneuvers to have bowel movements, or if they just have the sensation of anal rectal obstruction in a quarter of their bowel movements. They can't be meeting any of the criteria for irritable bowel syndrome, and they only get loose stools rarely without the use of laxatives. So those are the Rome criteria. Kind of the workup of constipation. There's something called a SITS marker study, where you ingest these radiopaque markers. You have an X-ray on day 1 to ensure passage into the colon, X-ray on day 5 to assess the passage. Greater than 80% should have passed. If less than 80% have passed or clustered, then this suggests some slow transit constipation. It's also reading if you have, and you just see these kind of radiopaque markers just kind of stuck all over your colon, like none of them have really moved, then you have something called colonic inertia. You can also see if it, you have them all towards the end, you can get pelvic floor dysfunction assessment. So this is a specific type of MR that you can get. It's a defecography to see if there's just pelvic floor dysfunction causing them to be constipated. And then also a colonoscopy is important to make sure that there's not like an anatomic cause for them to be constipated. The treatment is usually to increase stool bulk, which stimulates colonic motility. You have to have 20 to 30 milligrams or grams of fiber daily. Have to drink a lot of water in order to increase that stool bulk. Increase physical activity. Laxatives are helpful. There's the kind of bulking laxatives, which is fiber and mucil. You can have stimulants, softeners, and then the kind of osmotic laxatives like the lactose, the Miralax. And then slow transit constipation can be treated with surgery with the total abdominal colectomy, although this isn't done very commonly. It's a pretty dramatic treatment. Irritable bowel syndrome. So this is abdominal pain not associated with an anatomic abnormality. It may or may not be associated with changes in bowel habits. It's one of those kind of syndromes that's doesn't have a really clear pathophysiology, related to some emotional stress, psychiatric illnesses, just abnormal colonic motility, kind of altered myoelectrical activity, and then this question of kind of abnormal gut hormone secretion, but there's not like a clear etiology of exactly what it causes. So some of the different treatments are kind of treating any like psychiatric disorders. There's a lot of symptom treatment for diarrhea or constipation. Some anticholinergics have been shown to decrease some of the motility and bloating, and then tricyclic antidepressants have been shown to eliminate some symptoms. And that is everything. So the year 1 topics that we didn't cover today. So those are lower GI bleeds, diverticulitis, C. diff colitis, and ischemic colitis. Those are topics that'll be covered next year. So you should review those on your own. There's pretty big topics. I got all the questions earlier today from SCORE, and there are like 1 million questions on ischemic colitis on SCORE. So it's a common topic. Also C. diff, surprisingly. Those are my references, and that's all for just the surgical education presentation. We'll probably take about a few minute break. Let's say like 5 minutes, so everyone can like get up, stretch, go to the bathroom, and then we'll come back and we'll do our journal club article.